What recordings did you end up submitting?
So I think I had a case where a patient had dementia, an elderly patient. So that was my elderly case. I was able to explore about the current issue and also about the psychosocial. So that was one case. I also had a case of baby reflux. I think the challenge was there because of the parental demands in terms of what the guardian says and what the parents was demanding. So that challenge was there. A simple case I submitted was a child with an upper respiratory tract infection, and then it was a case of antibiotics or not. I was able to dig into the past medical history and understand why that demand for antibiotics was there, and then use it in the clinical bit. Um, there was a pregnant lady with depression, history of postnatal depression, discussing antidepressants, the benefits and risks on the baby and things like that. Um, then there was another case of, I had a few mental health cases. I think those were the cases that I recorded on the phone. Quite a few mental health cases. Didn't really have much of men's health. It was, you know, for the criteria, which was elderly. So I've spoken about the elderly, I've spoken about the children. Um, I had a case of some joint problems affecting a kid that played sports. I think it was Schlatter. I think what I would say was a couple of my cases, I had a feedback where they said it wasn't really suitable for the RC in terms of showing um, the skills that were required. I can't really say for sure which cases they were, but I didn't fail any case if that helps. So even if they weren't you know at the standard of the RCA, they still passed. I may have scored lower, but they still passed. So overall, it was a good mix. Most of the children, most of the you know I would say physical problems, chest pain, things like that, were face to face. But for the mental health bit, anxiety, my woman's health, because it was also a mental health issue, was over the phone. So it was a good balance.
That's right. So, in terms of your acute case, do you remember which case did you submit?
I think my acute cases were a couple of cases, 2 week rules. One was a dysphagia who just wanted antibiotics. So I was able to negotiate, explain, and then it came to that point where the patient kind of understood the risk and accepted the referral. So that was the acute case. It wasn't just a case of, oh, you're going into hospital. I think that was my most challenging case, the acute, because I know it's easy to score very low there, even if they've said, oh, it doesn't have to be complex. You don't have to do all of these things. It's quite easy to score low if you just say chest pain, hospital.
That's right, yeah. So there was a layer of complexity because of the demand of the patient there.
Yeah, yeah.
Do you remember your long term condition?
So the long-term condition, I think the dementia was part of it. So it was a flare-up of a long-term condition. I think I just had to discuss, why the patient wasn't on certain medications because of, so it was elderly and long-term in one. Um, so why the patient couldn't tolerate certain medications to treat their long-term condition because of their comorbidities. So in that way, the complexity was reasonable, because of
Right.
because of the case. Yeah, complex.
So, that's very good. You've managed to get a selection of telephone consultation and then video recording. When you were actually selecting which one to submit, which one is not going to make the cut, what was the process? What did you do differently this time?
I think I picked those cases that had. I know this is quite subjective, but had a very good flow. If because I had quite a good good case bank. But if I felt a little bit like it wasn't clear what was going on in an aspect of the case, if I felt weird, if I felt off, then automatically that was gone. Because if I feel that way, the examiner is going to feel that way. So obviously, I know a lot of people are going to tell you the technical details of it, but I'll spare you all of that. So I went with cases that had a good flow, had a good rapport, felt shared, where the patient felt satisfied at the end, that had a very good closure, had a very good rapport from the beginning to the end, cases where I delved into, the patient's past medical history, picked up something that could have been easily ignored, things like that. So that did it for me. But because of my past experience of the clinical management bit, that's what I'm referring to. I just ensured that it was shared. Ensured it was shared. I wasn't too fixed on how complex it was. So yeah, exactly. And also if there was a clear diagnosis, that was another criteria I used. So if it was a case of dementia, reflux, could this be pyelonephritis? Are we dealing with sepsis? That was something that I ensured that it was clear that I had made a diagnosis and it wasn't vague. That's what I can say. Obviously, before I got to this point, I had already used the RAG rating to, mark the cases. But in terms of selecting the cases for the exam, I was very big on rapport, flow, that nothing, I won't say nothing, but avoiding cases that had a lot of doubts and at the back of your mind, you're not sure what's going on. Like this could have been this, but it could have been something else. I avoided all of that. I picked a very clear diagnosis, and a very good closure. So even if it didn't start very well, but they had a very good, nice, ending to it.
If you have been struggling with the RCA and have realized that doing it on your own might not be the best use of your time and resources, then book a call with me to see whether I can help you. If I can help you, then we can enroll you on the one-to-one coaching program. But if I can't, then at least you'll get some insights in your preparation. Click the link down in the description below to book a call. Take care, everybody. Bye-bye.